talk about emerging infectious diseases, and I think we're on the 21st anniversary of a landmark Institute of Medicine report on this.
Right.
Can you tell us a little bit about what are the determinants of emergent and re-emergent diseases, and would you define the two major categories of emerging infectious diseases?
Okay, so the determinants are its adaptability to, one, infect a human, and two, importantly, sustain the transmissibility among human. Because if you look at new emerging infections, an interesting 70+% are what we call zoonotic.
Okay.
That means they originate in an animal, jump species, and go to a human. Influenza is one of them. HIV is another one of them. You can just go on and on. They start off in an animal and they go to human. Some of them are just curiosities. They jump, they infect a few people, and they dead end. And every once in a while, you get something like HIV, which is a transforming global health phenomenon. So, given that as a background, the kinds of emerging infections are one that is truly newly emerging and one that is re-emerging.
Mm-hmm.
So a truly newly emerging infectious disease is HIV/AIDS for sure. Nipah virus was another one of them. Influenza is interesting because influenza is both an emerging and re-emerging. It's re-emerging when each year it changes a little and you need a different seasonal flu. It's newly emerging when you get a brand new pandemic with a virus that you've never seen anything like it before. So that's the one that bridges that chiasm between truly newly emerging and re-emerging.
Okay. I was wondering what's been learned since that report. Where are some successes and failures about emerging infectious diseases?
Well, the one, I wouldn't call it a failure, I would say a persistent challenge is the unpredictability of it. I mean, that's why when you ask, am I surprised? I say I'm not surprised because it's something that is unexpected, but it's not a surprise. Even though it sounds inherently contradictory, it isn't. So what we've learned is that microbes do emerge. Pandemics do occur. We also learned that the way that you can get ahead of the game is by having good surveillance in the field so that you don't learn about it when you're sitting in Washington, D.C. or New York or London and all of a sudden there are a whole bunch of people who are infected and you find out they got infected by something that originated in the Far East or some other place where you have generally the incubators for these things. So you need point of care in the field surveillance, diagnostics, and the capability of rapidly responding with the development of a vaccine or another intervention. And we've gotten better at that. We really have. I mean, if you look at what we do now about rapidly getting vaccines for different emerging infections, rapidly detecting things like the MERS coronavirus or the SARS virus, even though it's a significant and rather serious challenge, I think if you compare the capabilities diagnostically, vaccine, and otherwise that we had a couple of decades ago with what we have now, we definitely are doing better.
Right. So, Doctor, throughout our conversation, you've mentioned drug-resistant TB, MRSA, malaria. All antibiotics, antiviral drugs have a weakness, an inherent weakness. Could you tell us what that weakness is, and then what are you doing to combat that consequence of drug resistance?
Well, the weakness, if you want to call it a weakness, it's almost a fact of life that microbes, because of their replicative and mutational capability, adapt to whatever you throw at them, environmentally, drug-wise, immune system, what have you. So when you get an antibiotic or an antiviral and you treat someone, unless you completely eliminate that bacteria or that virus, you will naturally select for the mutation that is resistant to getting killed. So if you look at a virus, let's say you're infected with a virus, HIV, influenza, what have you, or a bacteria, it isn't one homogeneous microbe. It's a microbe that what we call quasi-species.
Okay.
There's a dominant component and a minor component. So when you treat, and you treat the sensitive component, and there's a mutation to become resistant, at the end of the day, if you're treating, you're going to be left with the resistant microbe. And that's what the microbe does to escape the antibiotic. And that's the reason why you hear a lot about it, and it's true. If you're going to use an antibiotic, you should use it appropriately. If you use it when you don't need it, you will inadvertently select for resistant microbes. So the overuse and inappropriate use of antibiotics is a surefire way to help the microbe select for resistance. The other is you need good diagnostic and hospital control practices, because much of the antibiotic resistance that we see challenging us now, certainly in the United States, is things that take place in the hospital, where people are there for long periods of time, they have weakened immune system, and they got a lot of antibiotics because they have complications. When you develop a resistant microbe in a hospital, you need good infection control processes to prevent the spread from one person to another, so that you could keep it dead-ended in the person who gets it and hopefully successfully treat that person. So it's an inevitability of the interaction between the human host's use of antibiotics and antivirals to suppress the virus or the bacteria, and the virus and the bacteria's inherent replicative and mutational capability to avoid the bad things you're trying to do to them, namely kill them.
Mm-hmm.